Let's talk about psoriatic arthritis. Now, psoriatic arthritis is an inflammatory musculoskeletal disease that has both autoimmune and autoinflammatory features. That both it is inflammatory and autoimmune in nature, and it usually occurs in conjunction with psoriasis. So, to medically define it, it is an inflammatory musculoskeletal disease that has most the autoimmune and autoinflammatory features characteristically occurring with psoriasis. Now, psoriasis in these patients is important because in spondyloarthritis, there's usually some kind of association with other diseases whenever we look at the spectrum, except for the ankylosing spondylitis, where there's only the formation of syndesmophyte. The rest of the all of the spondyloarthritis, there always some kind of association with another disease. Like in enteropathic, there's association with inflammatory bowel disease, and in psoriatic arthritis, there is association with the psoriasis of the patient. Psoriasis is a skin condition where in a localized form, the patient suffers from skin lesions which have both whitish fish-like scales. Now, in order to learn the psoriasis or to learn what happens in a psoriatic spondyloarthritis, there's a mnemonic for it, and each mnemonic refers to a particular symptom. Now, that mnemonic is psoriatic. So, psoriatic is the mnemonic for the psoriatic spondyloarthritis, with the P standing for pencil in a cup deformity. Now, pencil in a cup deformity is specific to one psoriatic arthritis and sometimes can also be seen in reactive arthritis, but it is more seen in psoriatic arthritis and usually considered an hallmark of psoriatic variety. The S starts for sausage-like fingers. Now, sausage-like fingers is a condition where only a single digit is inflamed. Rest of the digits are not. And because of this single inflammation, the finger, because of the swelling, gives an appearance like it's a sausage. So, this is also not only limited to psoriatic spondyloarthritis, it can happen in other spondyloarthritis too. Onycholysis and onychodystrophy, the destruction of the nail bed and the destruction of the tissue of the nails. Now, both of these can be found in the psoriatic spondyloarthritis along with rheumatoid factor that is negative. Now, this point is important because spondyloarthritis are usually seronegative, and with seronegative, we means that there is no rheumatoid factor and there is no cyclic citrullinated peptide in the blood of the patient. Next, the typical radiographic sign known as the ivory phalanx. Now, ivory phalanx happens when there is increased density of the bone, and because of the increased density of the bone, the X-rays are more absorbed, giving a more white appearance to the digits. And because of the more white appearance of the digits, it gives the appearance like it's ivory or whitish in the nature. So this is very typical in psoriatic spondyloarthritis, in contrast to reactive arthritis, where the hallmark is osteoarthritis, that is, there is loss of bone density, while in psoriatic, there's increase in the density. We also have arthritis multilane. Now, multilane arthritis is a type of arthritis which covers almost all of the body, most of the symptoms. It is usually considered the most severe type of psoriatic arthritis that can happen to a patient. Now, another one is telescopic fingers. Now, because of the both destruction of the bone tissue, the condensation of the bone tissue, the fingers of the patient start to shorten in length, resulting in small fingers which are characteristically known as telescopic fingers. Next, we have itchy skin. Now, itchy skin is again related to the appearance of the psoriasis in the patient. Because psoriasis is itchy, psoriatic spondyloarthritis patient also present with itchy skin. Last but not least is the cold weather. Now, psoriasis is a disease which is usually flared up in cold weather. So, just like because psoriasis flares up in cold weather, psoriatic spondyloarthritis also flares up in cold weather. So you can take this mnemonic and consider it a mnemonic for both the symptoms, for both the lab testing, for both the course of the disease, and the both the etiology. Next, we're going to learn about the pathogenesis of psoriatic spondyloarthritis. Now, what happens is that we have endothelial cell lining. Now, we do not know that what is the exact incitatory event or what happens that causes these cascade of events, but we do know that it is involved in some kind of autoimmune and autoinflammatory nature, and we do know that it has a genetic predisposition. Now, genetic predisposition comes from the HLA CW0602, because every patient with HLA CW0602 is present with patient suffering from psoriasis, and likewise it is also present in patient with psoriatic spondyloarthritis along with HLA B27. So we do not know the exact event, but we do know that there is some kind of injury to the endothelial cell lining. The endothelial cell lining here can be the skin or can be mucocutaneous. But either way, because of the injury, what happens is that there is a release of both cytokines, peptide mediators, and lipid mediators, that all kind of cytokines and chemokines are released, and because of this what happens is that there is recruitment and infiltration of a multitude of cells, and these cells include the PMN or the polymorphonuclear cells, which are kind of like progenitor of the neutrophils. We have the mast cells. Now these cells are the one which are responsible for the allergic reaction or the hypersensitivity reactions by releasing histamine. We have both the T cells, which can be both the helper T cells in recognizing the antigen or the site of the injury, or they can be converted into the plasma cell, releasing the antibodies if the incitatory event is some kind of infection. And the same is with the B cells, because B cells and T cells are both type of the lymphocytes. And when T cells are recruited, B cells are recruited with them. Now, because of this recruitment of multitude of cells, all of this, we have certain secretions at that site, and these secretions are what are known as the neuropeptides, and they are secreted by the axonal ends at that area, and these secretions are the one which promote the inflammation. They promote the endogenicity of the site of the injury. They promote the infiltration, recruitment of the cells at that site. So in general, these secretions improve or increase the inflammation at the site. Next, now because of all of these cells, there's also the involvement of macrophages, and these are specific macrophages in psoriatic spondyloarthritis. These are the ones with the CD163 addition molecule to them. Now, along with the macrophages, we also have some other cells, and these cells are the ones which get differentiated or get divided from the T cells and the B cells. Now, they can be the ILC cells or the intermittent leukocyte cells. They can be NK cells, that is the natural killer cells, which are cytotoxic cells. They can be mate cells or the mucosal associated inversional T cells. Now, these cells are the one which are usually found. These T cells are the one which are usually found at the site of the injury because they are found near the endothelium or the mucocutaneous layer. So these are the ones which usually give rise to both the helper T cells and the B cells, which are usually recruited at the first stage. Now, because of all of these, we have certain changes, and these changes happen in a progressive manner. The first one being their synovial and skin inflammation and proliferation. That both the synovium, the synovial cavity, and the skin. Now, synovium is of the joint that is being inflamed, and skin is the area that is undergoing psoriasis. Now, that area will have increased amount of inflammation because of increased amount of proliferation of both cytokines, chemokines, and all of these cells mentioned here. Now, because of this inflammation, there's edema at that area, there's erythema at that area, and because of all these changes, what happens is there is cartilage, bone, and intestinal damage. Now, intestinal damage can be subclinical, that inflammation at that site does not present any symptoms, and that is especially true in the psoriatic spondyloarthritis. But the damage to the cartilage and bone is very specific to the psoriatic spondyloarthritis. And because of the damage to the cartilage and the bone, we get erosion of the synovium or the synovial cavity. We get hyperostosis, that is the outgrowth of the cells or the bone, and we get multiple more symptoms which progress from the destruction of the cartilage at the synovium and the bone that covers it. Now, because of this damage and because of the release of the chemokines and the cytokines when they enter the bloodstream, that can result in variety of systemic manifestations. And these systemic manifestations can be from localized psoriasis to the whole of the body, from axial spondylitis to bamboo spine. The list goes on. But the reason for the systemic involvement always starts with the destruction of bone and cartilage due to the inflammation that is due to the cytokine and chemokine release. Now let's talk about clinical manifestations in psoriatic spondyloarthritis. Now, whenever we talk about clinical manifestations in this spondyloarthritis, we always talk about domains. Domains as in the areas in the body which are primarily affected. Now, these areas are usually the nails. Now, the nail lesions in psoriatic spondyloarthritis can range from ridging, narrowing, furrowing, to yellowish discoloration, to oncolysis, that is destruction of the tissue, from that to the dystrophy of the tissue. So, a variety of nail lesions can happen to a patient with psoriatic spondyloarthritis, and the percentage is about 90% with only patients with only limited psoriasis, and about 40 to 50% in patient with psoriatic spondyloarthritis. So they are more found in patient with psoriasis, but when that psoriasis becomes systemic and results in spondyloarthritis, even though skin lesions percentage decreases, you can still find about half of the patients with these kind of nail lesions. Next, we have dactylitis, that is the inflammation of the fingers, And due to the dactylitis, it can result from a variety of effects, such as it can result in a sausage finger, that is complete swallowing of the finger. It can result into the penciling of the bone or the pharynx. The variety of lesions can take place in a dactylitis, and it all happens from mild to the severe spectrum. Then we have the enthesitis. Now, enthesitis is the inflammation of the entheses. Entheses is the site where either a ligament or a tendon attaches. And because of inflammation of that site where it attaches to the bone, it can result in a variety of symptoms. And it is very commonly seen in patients with psoriatic spondyloarthritis. The next one being peripheral arthritis. Now, psoriatic spondyloarthritis is known for its peripheral lesions. In psoriatic spondyloarthritis, the axial skeleton is usually spared. We have more peripheral lesions than axial lesions. So, this is one peculiarity with the psoriatic variety. Other one being their skin psoriasis. Obviously, when we have psoriatic spondyloarthritis, we also have psoriasis on the skin, and that psoriasis can be both limited and can be all over the skin. Another one is the axial disease, but the axial disease is mentioned here last because one aspect of the psoriatic spondyloarthritis is that axial skeleton is mostly spared. Only peripheral lesions are found. Now, the clinical manifestations in a patient with psoriatic spondyloarthritis, which should not be ignored. Now, these are important in terms because they are often overlooked. Now, these can be eye inflammation, because eye inflammation can be both a transient conjunctivitis to anterior uveitis. It can be painful joint, and painful joints can be a simple tendinitis or enthesitis to a complete synovitis. It can be pitted crumbling nails. Now, these nails can simply show ridges or can show clubbing or show patterns, or they can show complete oncolysis and onchodystrophy. Again, the pattern of the lesions on nails depends upon the spectrum of the disease, where it lies from the mild to the severe end. Next is the swollen fingers and toes. Again, it is due to dactylitis. Next, we have skin rash. Now, skin rash can be both as part of the psoriasis and can be separated from the psoriasis, because an underlying arthritis can result in the rash or the erythema of the skin above it. Then we have heel pain and foot pain. Now, heel pain and foot pain come from, again, tendinitis. Usually, the Achilles tendons entheses is inflamed. Other foot pains can also come from, again, psoriasis in that area. Now, let's talk about laboratory findings. Now, there are no specific laboratory findings when it comes to psoriatic spondyloarthritis, but there are certain findings that can help with the diagnosis. Psoriatic spondyloarthritis is mostly a clinical diagnosis. It is not a lab diagnosis, but these tests can help with your diagnosis. Now, these being both the ESR, the erythrocyte sedimentation rate, and CRP, that is the C-reactive protein. ESR is raised because there is inflammation, and CRP raised because it is an acute phase reactant. And because it is a positive one, it is raised. Both of these denote that there is heightened inflammation going on in the body. Then we have lower titers of rheumatoid factors. Now, psoriatic spondyloarthritis, among all the spondyloarthritides, is the only one which has some small percentage of the population which presents with the rheumatoid factor. Rest of all of the spondyloarthritis do not have rheumatoid factor in them. Only psoriatic is the one which can have patients with rheumatoid arthritis. Even though that section is very small, it can still happen. Next is the presence of the anti-nuclear antibodies. Now, anti-nuclear antibodies are usually found in patients with autoimmune disorders. And because it is both autoinflammatory and autoimmune, auto anti-nuclear antibodies are found here. Then there is the anti-CCP antibodies or the anti-cyclic citrullinate peptide antibodies. Again, these antibodies are only found in patients with rheumatoid arthritis or patient with seropositive arthritis. It is not found in seronegative spondyloarthritis. Only a small section of the psoriatic spondyloarthritis patients can have anti-CCP antibodies. So presence of small titers or small amounts of CCP or rheumatoid factor does not mean that the patient is suffering from rheumatoid disease. Even though both the psoriatic spondyloarthritis and rheumatoid arthritis have almost same symptomology and also have same kind of progression of the disease, they are differentiated in their inflammation of the tissue, in that in psoriatic spondyloarthritis we have less vascularity, we have less cellularity, and there is less amount of destruction of the tissue, while in rheumatoid arthritis there is more cellularity, vascularity, and destruction of the tissue. Next, there's increased amount of uric acid. Again, because of the psoriasis, in psoriatic spondyloarthritis, uric acid is increased. Last but not least is the HLA designation B27. Now this one is the hallmark of all of the spondyloarthritis. But in psoriatic one, it is present in about 30 to 50% of all patients. So again, it is not present in as much amount as the other spondyloarthritis, but it is still present. Now, because all of these tests are non-specific or are present in small amount, there is not one specific test for psoriatic spondyloarthritis. So that's why it is more of a clinical diagnosis than a lab one. Next, we're going to talk about the radiographic findings. Now, radiographic findings are very typical in a patient with psoriatic spondyloarthritis. Now, as you can easily see, this is a patient with normal hands. It is a normal radiograph of a patient with normal hands. While this is a radiograph of a patient with psoriatic spondyloarthritis. Now you can easily appreciate both the destruction of the bone tissue, you can appreciate the thinning of the phalanges resulting in what is known as the pencil phalanges. You can also see that there is some extension of the joints at the synovial or the distal pharyngeal joint resulting in the outgrowth, and that outgrowth at these areas result in a cup-like manner. And whenever we have phalanges which have penciled out and they are present above that cup-like joint, we get a typical sign which is only found in either reactive arthritis or psoriatic spondyloarthritis, is the cup in the pencil in the cup sign, and it is only due to the destruction of the bone tissue due to the osteitis and hyperostosis. Next, let's talk about the diagnosis. Now, diagnosis of psoriatic spondyloarthritis needs to be done very carefully, and the way it's done is via a method known as the Caspar classification criteria. The Caspar classification criteria states that you need to have some kind of inflammatory articular disease with either three or more than three of these symptoms. So if you have an inflammatory arthritis or articular disease with three of these things, you can easily confirm via the guidelines that this patient is suffering from psoriatic spondyloarthritis. Now, these symptoms can be the direct evidence of psoriasis on physical examination. It can be typical psoriatic nail dystrophy. It can be negative rheumatoid factor. That rheumatoid factor is not found in the serum of the patient. It is either current or previous evidence of dactylitis, that some kind of inflammation is either going on in the fingers of the patient or has happened before, or there is some just a articular new bone formation. And narrowing of the space between the bones along with reactive bone formation is usually considered a hallmark of psoriatic spondyloarthritis. So an inflammatory arthritis with any three of these will, according to the guidelines, can give you a clear diagnostic criteria to diagnose the patient. Now let's talk about the treatment. Now the treatment of psoriatic spondyloarthritis can be divided by the area at which the damage is taking place. Now if the damage is at a peripheral arthritis site, it can be dealt with by using NSAIDs, that the non-steroidal anti-inflammatory drug. It can be dealt with by using intra-articular steroids. It can be used by using disease-modifying drugs. It can be used by using anti-TNF or tissue necrosis factor alpha monoclonal antibodies. Now all of these drugs in combinations can be used to tackle any kind of peripheral lesion or arthritis. Now because we know that in psoriatic spondyloarthritis, axial skeleton is usually spared and there is more peripheral lesions than central ones. So this treatment is of utmost importance. Then we have skin and nail disease, and skin and nail disease goes hand in hand with psoriasis. It is found in 90% of the patient with normal psoriasis skin disease and about 40 to 50% of the patient with psoriatic spondyloarthritis. So skin and nail disease are dealt with topical agents. They can be dealt with by using PUVA, by using the Solera UV lens A or UV light A and B blockers. They can be even used some kind of systemic immunosuppressant such as a methotrexate or cyclosporin, or even anti-tissue necrosis factor alpha can also be given. Now all of these, when given in conjunction, can give you relief from both the skin and nail disease. Now their application depends upon the severity of disease. If the nail is showing typical lesions of psoriasis such as ridging, yellowness, dystrophy, lysis, then only topical solutions are used. Systemic ones are not used. But if the situation has resulted in some kind of systemic disorder such as in mutilins, then both immunosuppressants like methotrexate and cyclosporin can also be used. Now, anti-tissue necrosis factor is used in almost all of spondyloarthritis because it has a very good outcome in almost any kind of arthritis, especially spondyloarthritis. Next, if the patient has axial disease, if the axial skeleton is involved, which is usually the sacroiliac joint, we give the patient the NSAIDs, we advise physiotherapy, and we give the anti-tissue necrosis factor antibodies. Now, if the patient is suffering from dactylitis, then we give NSAID injection and again anti-tissue necrosis factor monoclonal antibodies. And if the patient has enthesitis, that is inflammation of the entheses, Then we give the patients both the NSAIDs, physiotherapy, and the anti-tissue necrosis factor alpha monoclonal antibodies. And these monoclonal antibodies now also come as humanized, such as the case with the golizumab. Now, golizumab pagol comes as a humanized monoclonal antibody against tissue necrosis factor. Now, because it is humanized, there is less chance of antigenicity, and because there's less chance of antigenicity, there's reduced chance of any side effects which are usually associated with using with regular monoclonal antibodies, such as infliximab or delimumab. Now, because of the treatment of all of these peripheral site, including the axial or the central site, this results in the patient's recovery, and you can also reassess the response to this therapy. You can modify it, you can increase certain doses, you can relieve certain drugs, because certain drugs can have toxic effects. For example, the immunosuppressive drugs, the methotrexate and cyclosporin, has huge toxic effects both on kidneys and lungs. They are very hepatotoxic and nephrotoxic. So if your patient is showing some kind of toxicity, you can even modify this treatment. So in psoriatic spondyloarthritis, treatment is usually tailored according to the symptomology of the patient.